Dr. Woodard, thank you so much for being here with me today to talk about your amazing career and what you've done for our state and really on a national level too. And thank you for being part of Thrive's advisory board.
Thanks for inviting me. I'm really excited to have this conversation with you.
Yeah, you too. All right, I'm gonna read out all of your credentials. There's so many that I could not memorize all of them. So here we go. Stephanie Woodard, PsyD, is a licensed psychologist and a systems-level strategist focused on population health solutions to improve outcomes with an emphasis on translating research into policy and practice. Dr. Woodard earned a Doctor of Clinical Psychology degree from the PGSP Stanford PsyD Consortium in Palo Alto, California. You agree?
Yes, I agree. This is all true.
Yes, this is all true. She has taught undergraduate and graduate courses at the University of Nevada, served as a faculty for professional education for behavioral health and healthcare providers and administrators, and provides training and technical assistance to states and provides through national TA centers. Her clinical work focuses on co-occurring disorders, mental health, and substance use, mindfulness-based cognitive therapies, and well-being and positive psychology. And I just want to say, just being with you, that is something I didn't have to read that. I knew that about you. Dr. Woodard previously served as the State Mental Health Authority and Single State Authority for Substance Use Disorder Treatment, Prevention, and Recovery from the Nevada Department of Health and Human Services. In that role, she provided leadership to state agency teams, policymakers, community providers, government agencies, payers, criminal justice, and hospital systems. Her legislative work has included policy frameworks for 988 and crisis services, opioid settlement funding, expanding Medicaid-supported substance use treatment, and housing and improving access to harm reduction services. But wait, there's more. Her board service includes appointments to the Nevada Board of Psychological Examiners and the Attorney General's Substance Use Working Group. She has also served as Region 9 representative for the National Association of Alcohol and Drug Agency Directors, treasurer and board member of the National Association for State Mental Health Program Directors, and board member of its affiliated research institute. Dr. Woodard received the Robert Raymer, did I say his name right? Mm-hmm. Robert Raymer Professional Award in 2021 and the Distinguished Speaker Award from the National Latino Behavioral Health Association in 2022. That's amazing. I didn't know some of that stuff about you.
Surprising.
Yeah. Not surprising, but truly amazing. So, Dr. Woodard, before we even get into all of these formal questions that I typed out and wrote down, I just want to say it's so serendipitous that you have so much experience in treating and policymaking around substance use disorders because, as you know, one of Thrive's specialties is eating disorders and anxiety disorders. And those co-occur about 60% of the time with substance use disorders. And so I'm grateful that you have so much expert knowledge in that topic and that you're on our advisory board.
Thank you.
All right, here we go. Big list of questions here.
All right.
In your view, why is it crucial now more than ever for Nevada to have a specialized residential program that addresses both eating disorders and anxiety or OCD, especially given the state's current behavioral health landscape?
It's a big question.
It is.
So I'll start by providing a little bit of context,
Okay.
And that's in a more general sense. Okay. So in recent years, the Department of Justice has found the state has really neglected building a continuum of care, specifically around children's behavioral health. And this has resulted in a lot of children being sent out of state for residential treatment. One of the issues that we consistently find with residential treatment, whether it's in-state or out-of-state, is that there's really an emphasis on ensuring that the child has placement, but not a whole lot of emphasis on ensuring that there's a goodness of fit between the child and what their needs are, along with the treatment. So having specialized treatment in Nevada means that kids are able to stay closer to their families and caregivers, their natural supports, their communities, and we don't have to have children going out of state unnecessarily. When we have them go out of state unnecessarily, oftentimes their lengths of stay are much longer There's no guarantee that the milieu is really suitable for them. We've got lots of kids coming in with lots of different issues. And it's hard to imagine that one general psychiatric rehabilitation treatment facility can really meet the needs of all of the kids that are coming in.
Right.
So having specialized treatment here means kids get to stay closer to home. They can stay connected to school, family, friends. It also helps because parents and caregivers can be really part of and integrated into their treatment, which means that there's greater likelihood of success for them transitioning back into the home environment.
Well, and I love that you brought that up, because that's really at Thrive, that's really our mission. Is you can't just have an identified patient and treat them and have that be effective. You have to treat the person in the environment and the environment. And so that's something that we are really focused on at Thrive, especially with our pediatric population, is making sure that we help the family create a system, part of the system of care at home.
It's so important, right? I mean, nobody knows their children as well as parents and caregivers do.
Right.
And so having that kind of support and integration into care, be it inpatient or outpatient, is really critical to success. Your clinicians can only do so much to get to know the child and their issues. What are the maintaining factors? Where are their strengths? How do you build upon their strengths? Having parents as partners in that process is invaluable.
Right. And from an eating disorders perspective, when I think about that, just from a practical standpoint, I think about kids that may have an eating disorder, may or may not have a body image struggle that goes along with it. But when I think about kids that do have body image struggles, one example would be we send that person out of state, and maybe mom and dad are struggling, or mom and mom, or whomever is their caregiver in the home, are struggling with their own body image issues, their own judgments around food and body shape and size. And then we send the kid right back to that same environment without chatting with mom and caregiver and helping them work through those things prior to the kid getting home. So I do think that I see that need too. Let's see. From your state level vantage point, what gaps exist right now in Nevada's continuum of care for pediatric and adolescent mental health, and how can Thrive's new specialty residential program fill those?
The gaps are many. So throughout the entire continuum, we have lots of opportunity to grow prevention, early identification, and intervention, primarily in pediatrics and primary care. So opportunities to integrate behavioral health expertise into primary care and pediatric settings so that providers are better equipped to detect issues really early on and to either prevent those issues becoming worse so that they actually do need more formal behavioral health supports, or to be able to identify them really early on and get them connected to the care that they need. We have a wonderful pediatric access line specifically for child psychiatry, so that if a pediatrician or primary care physician does pick up on a need for medication consultation, they have immediate access to that, which is a great kind of stopgap measure because we certainly do not have enough child psychiatrists in the state to go around. So having that ability to pick up the phone and provide a consult is huge.
And offhand, do you know what that number is?
Not offhand, but I could get it for you.
Yeah, we'll get it, and we'll make sure we edit it into this video for sure.
Yes.
That's very helpful to know.
Yeah. And then, crisis services, also very lacking. We do have mobile crisis, and we're very fortunate to have mobile crisis now run by Washoe County up here in northern Nevada. And that means that any family who's experiencing a crisis with their child or adolescent can call toll-free any time, day or night, 365 days a year to get a response. And the way that the service is intended to work is that they will, collect some basic information, but really the goal is to get out into the home, into the community, into the school, wherever that child is, and really assess the situation and wrap around them and their families to make sure that they have adequate access to support. But outside of that, our crisis services are really lacking. We don't really have opportunities for crisis residential or respite services, which are really essential, especially if you've got a lot of complex issues that are happening in the home. And sometimes kids having an opportunity to step out of that home environment is just enough to sort of cool temperatures down and help support reintegration. In-home stabilization is also really very lacking. We have a lot of general behavioral health community providers that are great at providing screening and assessment and basic psychotherapy and support, case management, those kinds of things. But being able to go into the home to really work with the family to stabilize without requiring the child to leave the home is also really critical. We find it's a lot harder to get kids, once they've left the home, back into the home without doing a lot more intensive work with the family.
And that's so relevant to the work that I personally have done in my own therapy practice with OCD kiddos. It's so true that there's so much like family accommodation that goes on with anxiety disorders and with OCD, even with eating disorders. And unless you're in the home coaching families through meals, coaching families through maybe it's a difficult bathroom routine that a kid is compulsing through, it's really hard to affect change in an office setting because that's not the setting where the trigger occurs. And so I love that what we're doing is in alignment with what's really needed. That's great to hear. Yeah. Anything else you want to say about that?
Yeah, if you don't mind. So I think when we think of the continuum, intensive outpatient, partial hospitalization, residential treatment, inpatient, especially for pediatric populations, all very lacking. And so, we have this really, we have a system with a huge gap. So we've got sometimes like very basic general outpatient behavioral health treatment, which often is really not to the level that it would be effective. So if you're only seeing a therapist once a month and really your intensity of need is more like twice a week, once a month is not really going to be sufficient in order for you to receive the care that you need and achieve recovery. And then we have really deep end services. So we have inpatient and psychiatric rehabilitation. But what we know is that if at all possible, we want to be able to keep children in their homes, surrounded by natural supports, caregivers, being able to maintain education goals, really be able to engage in their community if they're engaged in after school activities, sports, art, whatever it is. The more that you can maintain continuity for a child, even while they're engaging in care, the more they're able to continue to be connected to the things that matter to them the most without having to take them out of all of those things and then work to reintegrate them. So, we can provide very high levels of care, even a residential level of care, while children are in their home with the intensity of services and supports that we wrap around them and their families. So I think just really critical that it's not a one size fits all. And that we've got a lot of work to do to build out the continuum in Nevada.
We really do. I was thinking when you were talking about keeping kids engaged in extracurricular activities, and I wonder, this is kind of off the cuff, so this is not something that you could have prepared for. But what if for us, the thing that we struggle with as eating disorder treatment providers is that oftentimes those activities are something maybe the child was initially related to and connected to in a healthy way, but all of a sudden the eating disorder kind of got its little claws in there and it turned into something that was an unhealthy habit or even hobby, or the want or motivation behind it became like losing weight. We've had competitive soccer players, competitive dancers that love those sports, and the eating disorder has found its way in and made those more about perfectionism or body perfectionism or those kinds of things. And so we have had to ask parents from time to time, let's have your child disengage from their sport that they love until they can go back into it with a different motivation. And I guess, do you have any ideas in situations like that? Where is there a different mechanism to get them to identify and engage with something extracurricular outside of their disordered behavior?
So I don't think we can value enough positive childhood experiences. kids need to feel engaged and really a sense of mastery and skill acquisition, but also just the joy of childhood.
Mm-hmm.
Being able to feel like they can engage in something where they have fun and they enjoy being around peers. They
Play.
enjoy learning a new skill, play. I mean, we
Yes.
cannot undervalue it. And I think that sometimes, especially in behavioral health treatment, we sort of modify treatment as if they are small adults. And we forget how important it is to really keep kids engaged in the things that they really do enjoy doing. And so I understand and I can see that there would be some therapeutic rationale for maybe disengaging with activities that maybe their relationship has shifted and they previously loved, but now there's a lot of additional like meaning or motivation attached to engaging in that. But if you're going to take something away, it's always important to be able to put something in its place.
Wow. That's a really meaningful thing to say. And we're totally going to take a clip of that and replay it. I love it. All right. Why do you believe that specialized care for OCD and anxiety is necessary rather than treating these diagnoses in a general mental health setting?
We have so much evidence to know what actually works and what is effective in treating anxiety disorders, severe anxiety disorders, and OCD. That if you don't have access to those evidence-based practices, you may receive some improvement from, engagement and supportive psychotherapies. Some of the family work can be really effective. But we know that for long-term sustained recovery, evidence-based treatment is really the way to go. I think the more that we can ensure that we are doing a good diagnostic evaluation on the front end and really knowing and understanding holistically, not just what the diagnosis is, but who the child is, what their assets and strengths are, as well as what their challenges are, then we're able to better tailor treatment to them. So I'm not a huge fan of being singularly diagnostically driven when developing a treatment plan because we miss so much richness of who the child is, what they're all about, really to support them developmentally, cognitively, physically, emotionally, as treatment providers. And so, in general behavioral health settings, you may have a specialist that specializes in anxiety disorders or OCD, and you may not. And one of the worst things that we can do oftentimes to families is underdiagnose and undertreat. So, if there's a reticence to give a diagnosis like OCD, because maybe a general practitioner doesn't feel that they are competent enough to be able to really get to that level of granularity for a definitive diagnosis, we may see that the child is undertreated. And that can be very discouraging, not just for parents and caregivers who are doing what they can to support the child in addressing their treatment needs, but also for the child, right? I mean, anyone engaged in treatment understands that there's work that has to happen on their behalf too. And how frustrating it is to receive what you think is treatment and good quality care, only to find out that maybe you weren't given the opportunity to really make use of good, solid, evidence-based practice.
And I find that families and individuals, adults, kids alike, that have engaged with a treatment that's not necessarily tailored to fit not only the diagnosis that they happen to be struggling with at the time, but themselves as an individual, they're more reticent than if they need it, which they probably will in the future, to engage with it again. And so I find that it can be harmful, just like you said, to undertreat, underdiagnose, give more generalized treatment rather than treatment that's tailored to that individual.
Yes. And oftentimes what we see is that depending on the door that you walk through, whatever that clinician sort of specializes in, what the modality is that they're really strongly seated in, is oftentimes what you're going to get. And that does not necessarily mean that there's been a goodness of fit between what they offer and what you as an individual actually need. And that can create all sorts of other issues, including therapeutic rapport, being able to feel like you are engaged in something that you have good faith that it's going to be helpful for you. Those are really active components in good quality treatment.
Yeah, they're critical. Okay, what data or trends stand out to you regarding access to early evidence-based intervention for youth? Any additional trends that stand out for treating youth with eating disorders or severe anxiety that you're aware of?
Yeah, so we definitely have a children's behavioral health crisis, so to speak. And depending on who you talk to, you can get lots of different theories around why kids are struggling so much right now with all sorts of things: depression, suicidality, anxiety.
Mm.
And I think that really there are a lot of very strong arguments to be made about why we're seeing such a critical need for support and service for kiddos. On the other side of that, I would say that, there sometimes is a tendency to over pathologize
Mm.
what could be seen as, sort of normative development. I think that there are a lot of demands placed on kids, and sometimes those demands are not developmentally appropriate, and they're not really individualized to what is going on with the child, where their struggles are. Context matters. And so is it an issue that's manifesting only in school, only at home, only with their friends, right? Is it something that's pervasive that really is a major issue or challenge that may need further investigation for diagnosis? Or is it just a regular kind of hiccup in the developmental trajectory? Are there some maybe basic life skills that need to be taught and supported to really help them move forward developmentally? I do caution that sometimes we have this tendency as a profession to sort of swing the pendulum in either direction a little too far. And I think there is some danger in over pathologizing just normative development, especially when we're looking at a child compared to their peers as opposed to a child compared to themselves.
Mhm.
And I think when we take the child out of their own context and start to, measure them against their peers, sometimes we see that there's a pretty significant gap or deficit. But when you look at the child in context of themselves, it may not be as significant or severe, right? They may
Right.
just be uh, experiencing some kind of delay developmentally with a little bit of support and remediation, not a behavioral health diagnosis, but support and remediation can really get them back on track for normative development. When it comes to eating disorders and severe anxiety disorders, though, I do worry sometimes that we're not always thinking from a comprehensive evaluation that eating disorders may be playing a role. And I do think that a lot of behavioral health clinicians, if they have not had a lot of in-depth training, they may really kind of shy away from doing a more comprehensive evaluation to determine if an eating disorder is actually present. Or they may see that an eating disorder is present, but not really know how to treat it and start to treat some of the more peripheral issues. We see this in addiction all the time is, well, if we treat the anxiety, then maybe, the alcohol use will go down.
Right.
And that may be possible, but when we talk about co-occurring disorders, we actually have to treat both disorders simultaneously. It's not one
Yes.
and then the other.
Yes.
And I think we can fall into some of that thinking with eating disorders and severe anxiety disorders as well.
I think you're so right about that. I notice a lot, especially when I'm working with clinicians where that may not be their specialty or they may not have a lot of training in that. Even with suicidality, for example, a child or an adult or whomever will be suicidal or even passively suicidal, and they will want to treat the depression. Well, meanwhile, this child or this person has lost a significant amount of weight, and we know based on randomized controlled trials and things like the Minnesota starvation study that even just dropping weight with or without a body image struggle can lead you to cognitive rigidity, obsessive thinking. We see a significant increase in suicidality. And so important to treat chicken or the egg, yes, the depression too, but sometimes we can't even know, is it a true depressive disorder we're looking at without also making sure that we're feeding this person appropriately. I think with the dawn of GLP-1s, my prediction, this is not evidence-based, but my prediction is that now that this particular body type, we have people like Serena Williams who had this beautiful goddess body that was an athlete, a competitive athlete that has chosen to change the size and shape of her body. I don't know if she has a medical issue. Maybe she does. But there's a lot of little girls out there that don't have thin Euro bodies, that are watching her and seeing what she's doing. And so I do wonder, as our culture shifts more into these thinner bodies, are we going to see a significant increase in eating disorders with the dawn of GLP-1 and tirzepatide and those kinds of things?
Yeah, it is interesting the role that societal pressures play in shaping what we see as not just normal, but desirable, right? Of having greater value that people strive to achieve.
Right.
And so there is a role, I think, also for families to be able to come in alongside their children and really help them develop what they think would be sort of a healthy normative approach to body image. Sometimes, families can inadvertently perpetuate some of the issues around body image and maybe hold to a higher esteem different ways that people look and behave. And so I think families also can maybe take a look and see how are they really approaching things like eating and self-image and how people portray themselves, right? I mean, I have 2 teenage daughters and, there's always an eternal struggle between like what is appropriate to wear in certain settings and everything else, right? I think that we sometimes as parents can undervalue the value that our children place on how we communicate what we think about certain things.
Yeah.
And that translates to body image as well.
I agree. And I think the relationship as parents, I too have a teenage daughter and a couple of boys as well. But I think the way we relate to our own bodies and our own selves, our kids are watching that and they're learning so much from that. And going back to your point about treating the family system, treating the child in the home, that's why this is important. The messages that they're receiving are coming from the parents' relationships with themselves, the parents' relationships with the child, just all of that. They're taking it all in and learning.
And oftentimes there's a mismatch, right, between what we say and what we do.
Yeah.
And kids pick up on that.
Yes.
They're really paying more attention to what they see us doing sometimes than what it is that we're saying, because there's so much more meaning in how we operate day to day in the world. So they're going to try and reconcile what is happening when we hear something very different than we see people behaving. And what's more trustworthy is our own experience.
What a great point. That's very true. And my kids will always call me out. If they see me being hypocritical, they'll be like, "You're a therapist, Mom." Sometimes it's harder on us. All right. So speaking of family involvement in treatment, how critical would you say family involvement in achieving positive long-term outcomes for adolescents for eating disorders and anxiety disorders is? That's a long question.
It is.
Let me rephrase.
It's okay. I got it.
You got it. Okay, good. Yes.
It's incredibly important.
Okay.
And I mean, just to go back to our conversation earlier, right? Like taking the child out of the natural environment, taking them out of the house where maybe the triggers and the dynamics, just the way that the family relates to one another, taking the child out of that oftentimes negates really how much influence environment and family and relationships have on each of us as individuals. And so having family involved, right, we have to recognize, one, I will say just philosophically speaking, I believe that every parent is doing the absolute best that they can with what it is that they have available to them. And that is informed by their background, their experiences, their view of the world. And if we come to recognizing that parents are doing the absolute best with what it is that they have, I think it's easier for us as clinicians to really invite them in to helping us better engineer the treatment that is available to meet the needs of their child. Nobody knows their needs, their strengths, their idiosyncrasies, all of it, as well as that parent. And so those parents and caregivers, be it natural parents, foster parents, or other formal caregivers, they really play a critical role in helping us understand that child, but also setting up an environment and the relationships in a way that can really support the changes that that child is seeking to make. And that's everything from the built environment, right? And are there things that could be done in the home to really change it in a way that is supportive of treatment goals and outcomes, and relating? But that caregiving relationship cannot be undervalued, because, quite frankly, it is the thing that is most enduring. As clinicians, we are in a child's life and a family's life for such a short, finite period of time. And if we're doing our jobs well, at some point, we're going to be able to let go and let that family system come around and support that child, to the best that they can to continue to support them through recovery. So recognizing that we have a short window of time to be able to be with them, to do what it is that we can to support that family, and ultimately building the skills necessary so that that family can continue to work with their child.
Yeah. Somebody told me once the medical field and the mental health field are one of the only jobs where your job is to work yourself out of a job. And so that's so poignant and relevant. And I think, one of the things we say to parents a lot in the course of treatment from eating disorders, from anxiety disorders, is you did not cause your child's struggle is not your fault. You did not cause your child to have a disorder. These are biopsychosocial issues. And you are the key to helping your child come out of this disorder. You're not the problem, you're the solution. And so I love thinking about it that way too.
And it's a delicate balance, right? It is a delicate balance to say that now that we have this in front of us, we can partner together for the solution without too much of a focus on how we got here.
Right.
And recognizing that how we move forward, we're going to have to pay a little bit of attention to how we got here without blame and shame. Right. And I think the words that we use in our approach really can make or break that kind of dynamic. Because if the message is, and if we can honor the fact that most parents who are walking into the room, whether they vocalize it or not, are going to be carrying a little concern that they did something or they didn't do something that contributed to this, right? Are they to blame? Is there some shame? And so if we can recognize that all parents are likely walking in with that, and if we can make space and room for them to be able to voice that and explore that in a way that's very non-judgmental and supportive, we can actually partner together to resolve and address some of that. What is oftentimes unsaid can actually make change a lot harder because we're not able to bring that out. And there may be some beliefs and behaviors that are really maintaining some things in the environment that parents may not even be aware of. So I think creating a space for parents to be able to come in and really talk about what their perception of the struggle is and what they may or may not feel they've done to contribute it or maintain it. We owe it to them to provide a safe space for them to explore those things.
Yes, fully agree. So you mentioned earlier, sometimes we treat children like little adults. We do therapy with them like they're little adults, but they need play. They need a different way to take in the information and a different way to learn. So in that vein, why do children and adolescents with eating disorders, anxiety disorders, OCD require a fundamentally different approach? Not necessarily modality, but a different approach than adults.
Developmental needs. And as I said before, developmental needs are going to be different depending on each individual child. Okay. Doing treatment to a child is very different than doing treatment with a child. And so knowing and understand where they are by way of language acquisition, right? Okay. I mean, so much that we do is, especially in sort of talk therapy, is cognitively mediated, and we use a lot of language. If developmentally they're not at a place where they're really able to translate thoughts into words and feelings into words, we have to find another way to be able to access that information and allow them to express it, so that we can have it present in the room so that we've got something to work with. And play is an excellent opportunity for us to be able to bring forward some of those things, right? I mean, imagination, really, being able to be in the present moment and be able to have joy and laughter. Treatment doesn't have to be so serious all of the
Yes.
time. And actually, I think that sometimes when we make it too rigid and we make it too serious, it's harder to engage kids because it's not the language that they use. That's not how they typically interact with their peers.
Right.
And there's so much learning that takes place that transpires through play. That's how we learn about our worlds. That's how we learn about other people and how we interact with one another. I think when we look at language acquisition, cognitive ability, physical development, not every child develops physically at the same rate. And so we may have hypotheses around, why is this child underdeveloped? Why are they underweight? Are they, small for their age, right? We have to be willing to also sort of hypothesis test
Sure.
and not necessarily jump to conclusions that, oh, this is why
Right.
they appear to be the way that they are. It's
Mhm.
like, let's think about it. Let's talk about it. Like, I'm 5'3". My kids are not going to be 6 foot tall, right?
Right, right,
I
right.
mean, my kiddos have always been on the smaller side.
Mm.
And so, as a parent, if I were coming into treatment with my child, I would want some of that to be taken into consideration
Yeah.
so that we don't miss the mark and we're paying attention to things that might be noise and more of a distraction than an actual problem. I also think that it's really important for any kind of treatment provider that's working with children and adolescents to really think of where the sort of developmental trajectory is for that child
Mm.
and to be able to meet them where they're at. Because if we're providing treatment that requires them to really engage in a way that is outside of their capabilities, we're setting them up for a lot of frustration and unfortunately sometimes treatment failure because it's not meeting them where they're at and recognizing the skills and the skill acquisition for them to be able to move forward.
Right. And just listening to you and kind of taking in what you're saying and thinking about one of the things we do talking about developmental trajectories is the physical trajectory. We're looking at that in eating disorder treatment. So we often work with pediatricians to obtain growth charts to see, okay, where does this child, what is normal, if there is such a thing, for this child's trajectory and this child's development? And I think if you're working with a provider that treats eating disorders, not only is the developmental trajectory important from a psychological, cognitive, language-based perspective, but also just a physical perspective. There's no one size fits all. We're human beings. We're all different sizes, shapes, heights, all of those things. So I love that. Never assume. What a great thing to say. Okay. What are the most common pitfalls you see when programs attempt to, hold on, we kind of just covered this really. When you see a program attempt to adapt an adult-based treatment model to a younger population?
Yeah, I think just to underscore what I already said, right?
Yeah.
Children are not small adults. We can't, and even in the adult world, oftentimes we see a one size fits all
That's
approach
true.
to treatment,
Yeah.
and we don't necessarily see time taken to really look at how do we individualize this treatment to allow someone to make the most use of it,
Mhm.
and how do we move forward with treatment without saying, okay, we're just going to continue to move forward regardless of whether we're checking to see is this actually having the intended impact? Are there other things that need to be done, whether we slow down or we change our approach, we change our language? I think sometimes we forget, we get so treatment goal oriented that we forget to sort of pause along the way and
Mhm.
remember that we need to be checking in to see how is this actually working? Because, there are times having worked with lots of people with addiction, for example, what it looks like for someone to be in recovery and for someone to actually be in recovery oftentimes can be very different. And so
Mm.
you can have people feel like, yeah, if I'm just doing all of the things, then I'm in recovery. But if we're not getting to those deeper levels, those layers, we could see, someone's finished an 8-week course of treatment with intensive CBT and others, and has abstained from substances. But if we and we could say that was treatment well done.
Mm.
But if we're not taking time to actually evaluate, are there changes that are happening at deeper levels that we know are necessary in order for sustained recovery, we could actually really miss some critical opportunities for other intervention.
What a great point. And that really leads me to my next line of questioning, which is more around how to do care well for folks who are dependent on their insurance company authorizing care, because a lot of times when our utilization review team will be on the phone with another utilization review person at the insurance company trying to explain, like, here was the treatment plan, here's how these person hit the marks, and that deep part that you're talking about gets missed. And it particularly gets missed when we're talking about things like maybe this person is addressing some of the deeper issues, which are going to create more sustained change, but their frequency, intensity, and duration of behavioral change isn't quite lining up with what maybe an insurance company is really hoping will happen so that they don't have to authorize payment forever, which is understandable because resources are limited. But it's tricky in that way. I want to just name that out loud. So let me ask you this question relatedly. If you were advising insurers today, what policy recommendations would you give to expand access to care for eating disorders and anxiety disorders, OCD, that kind of thing?
Well, one, I would say it's more costly over the long term, not just from a financial standpoint, but from a human cost standpoint, to discontinue treatment prematurely.
Okay.
We really want to make sure. I mean, so much of treatment is skill acquisition, whether it's thinking new ways, feeling new ways, behaving in new ways. It really is an acquisition of skill, and then your ability to generalize that into life. You have to have an opportunity to generalize that into life and to test it.
Right.
And so I think, for me, I look at things like continued state criteria. You were just talking about some of them, right? Like, is this level of care appropriate? Is the dosage for duration, frequency, intensity of treatment, is that the right fit? Yes, and we know that because we're starting to see progress. But just because you're starting to see progress or you've actually met some treatment goals doesn't mean that other treatment goals aren't necessary in order for you to continue to help that person, that child move into being able to take what it is that they've learned in treatment and begin to really generalize it into their day-to-day lives. Sometimes when we let go too quickly and we transfer or we discharge people from care before they're really ready, we've kind of removed the scaffolding or support prematurely, and they're not able to really continue to make some of that progress. And so better for us to keep people engaged, even if it's longer than sort of medically necessary, because we want to make sure that we have not only helped them achieve their goals, but those goals can continue to be worked on, and the progress can be maintained after we pull some of those formal supports away. And so oftentimes we can see that we've got a little bit of a tail towards the end of treatment where it may not be at the same level of intensity as it was before, but you're able to still do check-ins and boosters and everything else that is necessary to really help that child continue on with progress. And we also recognize that for some severe behavioral health conditions, that there may be periods of exacerbation, especially when increased stressors occur, major life events, those kinds of things. And so I think also being able to provide some anticipatory guidance to say that, we're finished with active treatment now, and moving into the future, if there are other times where you have increased signs and symptoms, here's the recommendation. You can always come back for boosters and the like. I don't think that from an insurance perspective, they're always thinking about that entire continuity of care and what it means to move from active treatment into sustained recovery.
Right. That's a tricky one. It's always a balance. Okay. Final question. What excites you most about the opportunity for Thrive and Thrive's new greenhouse program or residential program to help shape the future of mental health treatment in Nevada?
I'm excited that we can actually build programs to treat the kids in our communities, keep them in our communities. As we discussed before, there are a lot of challenges when kids have to leave their community, leave their friends, leave their school and their families and caregivers to go elsewhere for care. And it's much harder for them to reintegrate and re-engage in all of that when they come back to the community. So to be thinking that we can actually have a program here in Northern Nevada to be able to treat our children in our community, and that can establish not only expertise within the community, but you become part of this much larger system of care for children. I do believe that all tides rise all ships, right? And so when you've got people that are doing exceptional work in the community, you in the program, it's not an island, right? It has a huge impact on the rest of the community, and can really be an asset to not only increase the quality of care, but ensure that we've got great access.
Awesome. Well, I really appreciate you as always. And thank you so much for being with us today and answering these million questions I had for you.
Thank you.